Any closing thoughts you have about where the field is going? Where are we going with the future? What would you like to see? What do we need to have?
A cure.
Yeah.
But I mean, where things stand at this point, when I talk to patients, one of the first things that I talk about is, can we get you off of medications? Can we get you off of ADT and ARSIs? So I'm relatively aggressive when it comes to that last patient that you talked about. Even if there were 7 mets, radiation keeps getting better. They're targeting better. The stereotactic radiation it's just better. And every generation of machine is better. So I would go for local control, whether, if they had urinary symptoms, then out comes the prostate. If they have no urinary symptoms and it's a small prostate, consider radiating the primary. But you start spot radiating. Put them on a year or 2 of ADT and then get them off and see what happens. Because I think and the ones that I've done that with over the last several years, they're on it for 18 months. And now a year later or 2 years later, they're still off of all medications. And their PSAs are staying undetectable. And, when you get follow-up conventional imaging, there's nothing there. So I'm pretty aggressive personally about doing that kind of stuff. And I think that, as more and more treatments come up that would potentially allow us to get off of ADT and ARSIs ARSIs, I think it makes more sense. Everybody's living longer, and if you start on these medications in your 60s, it will have significantly affected you if we do make it into your mid 80s or early 90s. And I think that that's something that we're focused on the initial disease and just getting you to 70. But nobody really is considering the 75, the 80, the 85. And I would love to see more of things like the lutetiums or the new alpha emitters or whatever hitting the market to potentially achieve these cures that we kind of would love to see. Because ADT and ASRI, as much as it helps with prostate cancer, is not the answer. I'd like to see it move well beyond those.
I would love to see progress. So if you come in and give therapy, somebody comes in, 7 bony mets, you give therapy, and 6 of them melt away, and there's 1 that progresses. Why? What is going on with that one unique bony met? What is the cell biology that makes the majority of the host issues resolve, and yet that doesn't? And I don't know that we know that yet. You go in there and biopsy it, and okay, did it morph into a different cell type that happens more in the prostate, not so much in the metastatic lesions? I don't know. That's kind of what I would love to see.
The thing I'm most excited about is further risk stratification of these therapies, so for better sequencing, whether that's new genomic markers, whether it's AI, pathology slides, all of these things that can and will be developed to help guide our sequencing. When can they come off therapy? How long do they need to be on therapy? Which therapies are going to be best for them? Which aren't going to work at all, and you're completely wasting time and money. And even getting biopsies from that one met that you said that did progress. What's different about that? We've got to stratify these better to guide therapy.
Brian, the big bill in Congress just gave you a bunch of money. So how are you going to spend that for prostate cancer development? What do you want to see come down the road to help?
Jeez. Tough question. Yeah, I was thinking it before you got into this, my mind was distracted here, but I was thinking neoadjuvant, because I think other tumors, when you think about rectal or other organ systems that are often giving, even bladder, you do a lot of bladder work.
Sure.
Giving it up front and then removing. So it seems like we would move to that at some point.
I think we have data that's still coming out for that. I think trials are emerging from that.
But I think it's going to be a lot of genetics, a lot of AI stuff that he's saying, just figuring it out. I don't know a ton of the breast cancer literature, but they seem to be early on, following some of their lead on things. And, it's such a long window for prostate, so it's harder to study. But it seems like every drug is just getting moved further forward,
Yeah.
Let's bring it home with our CMO to wrap up with final thoughts. Do you have anything else you'd like to add?
Yeah, I think on that note, biomarkers in general, I mean, everyone keeps kind of saying the same thing, trying to personalize medicine so that we are not giving drugs that aren't helpful, but we're giving ones that target that specific patient to have them live longer with least side effects and increased quality of life, right? I mean, that's what our goal is every time. So trying to, whether it's ctDNA that's coming along or all the other biomarkers that's, you know, targeted to look for what drug is correct for that patient. That, and you mentioned risk stratification, and what it starts coming down to is how can we make this, although we want to, like, always preach, you know, taking care of that individual patient, but at the same time having standardized pathways that makes our job a little bit easier, in that we know what we need to give when with sequencing, and so that we have more physicians, more providers in general that can do this, because we know with, you know, all the other trends that we have to deal with on a day-to-day basis, with shortages of urologists and not having enough providers to see these patients. How can we make it easier for a provider to deliver the right medication, the right treatment to the right person at the right time? You know, I think that's really the goal for all of us.